Hello, I'd like to think about some of the painkillers we might use for patients with hip fracture, thinking in particular about the complexity and the frailty of those patients, their cognitive difficulties, their risk of delirium, but also about the nature of the fracture and the implications that has for the sort of analgesic you might offer. There are a whole range of drugs that we could think about. Happily, I'm not going to think about several of those for reasons that I'll quickly run through. I'm not going to think about codeine. Codeine might be useful for patients who've got a bit of residual pain at the point that they're going home from hospital. But in the management of acute fracture, codeine simply isn't strong enough. So it'll give you constipation, but it won't give you enough relief for an acute fracture pain. So we don't use it at all. I'm not going to use slow-release morphine or slow-release oxycodone in my routine practice. These are long-acting drugs. They're therefore slow to establish in the patient. They're fairly inflexible, and given that the fracture pain is going to go away quite quickly and then the patient's going to progressively improve, they're relatively difficult to take people off again appropriately. So I think using a shorter-acting opiates is more flexible and more consistent with the nature of fracture pain that I'll come on to. You could make the same argument for the use of topical buprenorphine. You choose a patch, you stick it on, you hope it's the right size patch for your patient, but if it's too weak, you're going to have a couple of days before you can really tell whether that's so. If it's too strong, it may take a day or so for it to wash out of the system if you peel the patch off. So they're inflexible, but they are a useful option if you're dealing with somebody who's unable, for reasons of swallowing or indeed behaviour, unable to take oral forms of opiate and is in pain as a consequence. I'm not going to talk about non-steroidal anti-inflammatories, giving non-steroidals to patients when you're not entirely sure of their past gastrointestinal history. Their renal function is commonly very impaired already. The risks, complications, particular acute kidney injury in the perioperative period, and concerns among surgeons about the potential for non-steroidals to interfere with fracture healing mean that they're something we very rarely use. I'm not going to talk about gabapentinoids. These drugs take a couple of weeks to build up in the nerves before they'll start providing any analgesic effect. So again, they're not really relevant to the acute pain of fracture management. And I'm not going to talk about antidepressant therapies because we're dealing with a group of patients who've presented to us as a result of a fall, and the implications of antidepressants for falls risk would lead me to look somewhere else. And I think it's useful to talk about the management of fracture over the first 3 days. So this is a notional description of the first few days after somebody presents with a fracture. There isn't a y-axis to this graph. This is not precise science. But what we know is that if somebody falls and have a fracture, they're going to have immediate pain, and they'll be in pain while they're lying on the floor. If they're moving, that pain is intense. If they don't move, it dies back to a degree of sense of bruising and discomfort that's much less. Unfortunately, they don't get the option on lying still. They're transferred into an ambulance, they're transferred into the emergency department, they have to go to and from X-ray department, moving from X-ray machine to the trolley. Eventually, they get transferred up to the ward and onto a more comfortable bed surrounded by the people who'll be looking after them in the perioperative period. So managing pain over that period is challenging. In general, you might expect ambulance staff to give an injection of morphine to deal with the immediate pain before they start this process. And that may need to be topped up with injections or more conveniently, oral morphine during patients' time in the ED to try and cover some of the distress and pain. Problem with giving more morphine is that each time you give an extra dose on top of the dose that was there before, the levels in the bloodstream will accumulate. And accumulation of morphine means that the risk of patients becoming opiate toxic, particularly in terms of delirium, are considerable, and we need to try and ameliorate that. one thing that we can do is, of course, to numb the fracture pain at source, and fasciailiac blocks are a routine practice within the UK now, trying to minimise the amount of morphine that people need. The other thing that we should obviously be doing is giving some paracetamol, and throughout a patient's time in hospital, the role of paracetamol, though it's weak, the role of paracetamol as a morphine-sparing agent isn't something to be forgotten. So we can try and minimise how much morphine is accumulating in your patient using those measures. But the likelihood is that once patients are established on the ward, they will have had some morphine before they come to the hospital. And it's important to assess how much morphine they've had and how they've responded to it, so that you can start thinking about future doses and what is a suitable dose and a dosage interval to the size, the sensitivity, the cognitive status of the individual patient. And the problem patients face is that every time they need to move, trying to get onto a bedpan, being nursed for pressure care relief, every time they move, they're going to have more pain. And you can give additional doses of morphine before trying to move somebody, but there is a risk that that morphine accumulates. So how do we try and tackle that? It's very challenging. We could think about using oxycodone as an alternative to morphine. We know that in patients with renal failure, there's less risk of the accumulation of morphine metabolites, which can lead to toxicity with oxycodone. So we would use oxycodone in patients with renal failure. And in patients who are at risk of delirium or develop delirium, oxycodone is cleaner and less likely to cause problems. The difficulty with oxycodone is that in the UK, oxycodone is a controlled drug. That means you need 2 nurses to be free on a busy acute orthopaedic ward, 2 nurses to have time to go and open the drug cupboard and get the drug for the patient. And coordinating that, having the availability of the drug to give to the patient before the nursing staff try and move them in bed, or before the patient decides they want to reposition itself in bed, that's very inflexible, and it's relatively unrealistic. And certainly the cost implications and the time implications and the implications for what else nurses might need to be doing of routinely using oxycodone are challenging. So in our practice, we would routinely be thinking about morphine, except in patients where kidney disease or cognitive problems are a concern. And the implications of using oxycodone in those patients might be more justifiable. So we're seeing a situation of patients having episodes of pain, but those short-lived episodes of pain are leading to long-acting accumulation of opiates. That's, of course, what you want to try and do when somebody's got pain from perhaps cancer, where there's a continuous gnawing pain. The patient needs you to give enough morphine until you've accumulated enough in the system to stay on top of their pain, and that's what people are trying to do in cancer management. That's unfortunately not the situation for patients with hip fracture who, as I've said, aren't in pain when they're lying still. They have episodes, incidents of pain, and this incident pain nature of hip fracture care, it makes us need to think of a completely different strategy. And the strategy we have, of course, is that we operate. And to get somebody to theatre is uncomfortable of itself. There will be some post-operative pain, additional bruising, and so on in the couple of days following their operation. But fixing the fracture takes away these spikes of pain very effectively. The anaesthetist will give a nerve block to try and reduce pain in the afternoon, evening, night after surgery, to reduce patients' requirement for opiates again. But the next morning, we're going to try and get people up, and it's this process of getting up, starting to walk, physiotherapy sessions and rehabilitation that leads to our unit's approach, which is to have looked back over the amount of opiate that patients have needed during their time in hospital, found an appropriate dose for them, give them a dose, not on the PRN side, but on the regular side of the drug chart, a dose at breakfast time and lunchtime, which will carry them through the active part of their day. And that's not because PRN doses won't work, but if you walk around and ask a patient if they're in pain, they'll say no, and you won't give them a PRN dose. However, if you try and move their leg, as the physiotherapist is going to do 20 minutes later, they're going to be in pain. So we regularly offer opiates at breakfast and lunchtime rather than just waiting. However, we don't regularly give opiates at supper time and bedtime because that gives the opportunity for the brain to clear, for the bowel to work at a time when the patient's back in bed, probably not moving very much overnight. And PRN doses can be made available to cover the evenings. So we've got these doses morning and lunchtime just to get things started and allow people to get up and be active, but not routinely giving it all the way through the day. That's our approach, and then gradually we will adjust the doses of those. You talk to patients each day, and daily adjustment in the size of those doses to make sure that you're staying on top of the pain and that's not limiting them in their rehab is how we would approach things. Over their time in hospital, they're likely to come off morphine, and most people will go home on morphine, on paracetamol alone, perhaps with a little bit of Oromorph made available, oral morphine available for them to cover episodic pain in the early phase after recovery from hospital. What do we do if we can't operate, though? How do we approach the patient who's very frail, who's not operated? That's only a couple of percent of patients in the UK practice. What can we do for them? We can give them morphine, but they're still going to need to be moved in bed if somebody's having end-of-life care, or if somebody's just not fit for surgery, but still is going to try and make an attempt at recovery. How do we manage their pain, these episodes of pain? We can try and give them extra doses of morphine each time they try and move. We can think intelligently about exactly how much morphine we want to give and try and give them a more appropriate dose. Or we could even think about giving oxycodone to reduce the total impact of opiates on them. But however you approach things, if people are moving around, as they will be, trying to rehabilitate or just having nursing care at the end of life, there is an inevitability about the accumulation of oxycodone. And the fact that people are moving several times a day can trigger them having several doses of short-acting opiates, which can then translate into their being put on long-acting opiates or even on syringe drivers. But what that means is that there's an accumulation of analgesic in these patients. And for some patients, that may be entirely appropriate, that they're kept comfortable and peaceful at the end of life. But for others who are intellectually alert, who may be trying to make an attempt at getting through their illness, trying to rehabilitate, the accumulation of opium can take away their ability to do that, or simply take away their ability to have some time when the brain is clear enough to take their leave of their family, to say their goodbyes. So it's difficult to treat these patients. What you really want is a short-acting drug, a powerful analgesic that works just for a short period of time, so that you can give that before somebody gets up, before somebody's moved, but doesn't leave them full of opiates when they're resting and much more comfortable, not moving the hip. One possibility is using sublingual fentanyl, so somebody sucking a tablet or a lollipop during the time that they're being moved. But again, this is a controlled drug. It takes 2 nurses to administer it. You've got to anticipate when they might want to move or they might need to get up. Find 2 nurses to give them that dose before that happens. And that's really challenging to use in real practice. Intravenous fentanyl achieves very much the same thing. And happily, intravenous fentanyl is a technology that is much more available than you'd think, in that pretty much every trauma ward in the country will be using intravenous fentanyl in the form of patient-controlled analgesia in the post-op period for some of their patients. So the availability of patient-controlled analgesia with intravenous fentanyl allows the patient to have control over their pain relief. They have a red button they can press if they fear pain or are going to be in pain. And as a flexible means of allowing them to control their analgesia, we found that really effective for the non-operative rehabilitation of some of our more dynamic individuals. And using it in the end-of-life care, on the early stages of end-of-life care for some patients in whom operation isn't viable, has allowed them to be alert, free of pain, in control of their situation while they take their leave of their family. So it's a resource that's worth thinking about. Thank you.